well, welcome to our last COSSI Knowledge Exchange meeting for the year. Very exciting to have two presentations on TIP and some incredible TIP work that's been done in New South Wales. They're mostly both on TIP, aren't they? Yeah?
Yeah, it's one presentation.
Oh, it's one.
Yeah.
Oh, I thought you were speaking, one presentation, two people.
Yeah.
Is that why? Okay,
yeah,
no problem.
Right.
All right. Well, listen, look, to be honest, we all know you and we're delighted to have you speak today. So why don't you introduce your talk? It'd be fantastic to hear today.
All right. Thanks very much. We're going to go stop our video and then share our screen. Did that work?
Not yet.
Oh, hang on. Oh, share screen. That is what I have to do. You'd think I would get it after all this time.
So you're both presenting on the combined results of 5 TIP studies in New South Wales.
Yes.
Okay.
Okay, that should be now. You seeing that? Okay. All good?
Can you see?
I'm just going back. Sorry, I was just, yes, all good. Go ahead.
All right. Okay. So thanks very much for giving us the opportunity to present our work here at COSSI Chem. And we'd just like to acknowledge the traditional owners of the land in all of the places that we are meeting, all of the places where our studies took place, and pay our respects to the elders, past and present. And we'd also like to acknowledge the Aboriginal researchers and the participants who share their knowledge and experience with us in these studies. So, I mean, if any of you don't know, TIP is a guide developed by the World Health Organization to help health services identify pockets of low childhood immunization coverage and gain a deeper understanding of the reasons behind that and what strategies would be effective in improving coverage in that unique context. TIP uses social science, behavior change theory, and collaboration with all partners, including parents. And there are so many people and services to acknowledge who've been involved in these projects. So we'll have include a slide at the end to acknowledge them. So Kasia and I will talk for about 35 minutes, and then there's lots of time left over for discussion. This is an overview of what we'll be talking about today. We have to squeeze 4 years of work into our presentation. So there's just some things that we haven't included, and that's the quantitative methods and results behind the studies, the detailed qualitative methods, and the individual themes from each study. So we'll be more looking across the similarities and local differences. The design of tailored, we won't be talking about the design of tailored strategies in each community, as this is a work in progress, although we will be looking at some evidence that is emerging from the tailored approach in Maitland. And rather than putting slides up with quotes from participants, we've tried to incorporate the participant language in our presentation. All of these things that we haven't included are available upon request if anybody's interested, or can be found in our publications. We'll also be looking at some lenses that we've used for analysis, some models and frameworks, and what are the implications of all this for health services and public health. Where to next, and some good discussion. So these are the locations where our studies took place in New South Wales. And our work focused on Aboriginal children in Tamworth, Kempsey, and Lismore. So what is social science anyway? Well, it can be defined as any branch really of science that deals with human behavior in its social and cultural aspects. So we're not surprised to see public health, psychology, and sociology there, but it also includes economics, politics, and history. And there are other branches too that are not included there. And social science has been really important, made very important contributions to health research, like helping us to understand the consequences of discrimination, the impact of socioeconomic position, the role of power and politics in shaping population health, and how to use multi-level interventions that improve population health. And how have we used it in immunization research? Well, we do use it at the individual and interpersonal level in understanding vaccine choices, beliefs, and values. We use it to understand health systems and how effectively they meet community needs. And we are interested here in the social structures that support or hinder access to services and government policies that impact on individuals and families. So Kasia is now going to tell us a bit about our TIP methodology.
So community and stakeholder engagement, interviews, and focus groups are elements of TIP methodology. But today we will not talk about those. Rather, we will focus on some of the unique things that we did to tailor TIP approach to local needs. I'm also going to briefly talk about participant groups. In TIP, you want to talk to community groups and health providers. For us, community groups included parents, grandparents, carers, and community organizations. And then health providers included community health nurses, Aboriginal medical services, GPs, practice nurses, and also health managers or coordinators from public health units and PHN. We applied a cultural lens in 3 out of 5 projects, and Susan will talk later on about what does it mean to apply cultural lens. We also used sociological and ethnographic methods to help us better contextualize findings. And these included, first of all, taking a sociological walk, which involves walking in the community and noting elements of the built and natural environment, services offered, where people meet and interact, and the sense of place, all of which can provide a deeper understanding of the community and the broader social determinants. For example, using that method in Umaina and Kempsey, we gained a better understanding of the distances that moms with prams need to travel to access services, in particular where public transport is not available. Or we also were able to capture the feel or safety of the streets where many families live. In Umaina, we also saw the evidence of increasing gentrification. Another ethnographic method we drew on was searching through media and archival data to better understand the complexity of the relationships between different groups, the meanings of events, places, and buildings in which health services are currently held. And in Kempsey, using that method, which involved looking at 5 years of the Australian Broadcasting Corporation data and also excerpts from a contemporary art exhibition in the National Museum of Australia, helped us understand better the negative implications of the recent harmful government policies on the First Nations community today. While those policies of forcible removal of Aboriginal children from their families and racial segregation in health services cease to exist, they continue to live in the memory of many residents. For example, we learned that only 50 years ago, First Nations mothers were not allowed to give birth inside Kempsey District Hospital, or that in the national referendum in 1967, Kempsey had the largest vote against changing the constitution to include Indigenous Australians in the census. And that helped us understand why and how racism continues to characterize community relations in Kempsey. And now back to Susan.
Okay, so now we'll focus on our results, the similarities, and the local differences. So overall, really, we found widespread support for immunization. So generally, parents understood the value of immunization and supported it. As one mum said, it's crazy not to. You risk your own child as well as the other kids who've not been immunized. And really, parents were experiencing a range of obstacles and problems in their personal and family lives, like being very stressed or very busy and having these competing priorities. So at time, immunization just fell down the list. So someone said, I think there's a high rate of domestic violence and drugs in our area, and those families are so stressed. The basics come first: safety, clothing, feeding. Immunization would get pushed aside. And an Aboriginal participant said, if there's sorry business or other things happening in the family, that's a priority. Immunization will be put off. No one liked the three immunizations at one time, so that did result in some cherry picking. And despite the support, a significant number of parents thought more information needed to be easily available and presented in ways that were useful to parents. So that might include lots of detail, or it might be more pictures for those with lower literacy, and presenting more positive stories instead of negative. Someone said there's a lot of mums, especially first-time mums, who haven't had a positive role models, and they don't have that education. So then we came up with against the access barriers. And access barriers to health services did come up in all projects, and you are all probably quite familiar with them, like the transport, the hours, the locations, the waiting times, the cost. And personally, I've come to believe that these are the biggest contributors to pockets of low coverage. And lack of cultural safety is also an access barrier, where there's a deep and long-standing mistrust of government health services, and Aboriginal families will not use a service where they do not feel welcome and respected and where trust is lacking. One mum said, what I like about using the AMS is I know the people there, so I can explain my story and feel more comfortable. We also found many limitations within service models. So we know that most immunizations are provided by practice nurses in general practice. And apart from that, there really are not many other options for parents. And that GP model works well for most Australian families, and the high national and state coverage rates attest to that. But it doesn't work well for everyone. And unfortunately, that fairly rigid Monday to Friday business hours, appointment-based structure doesn't allow for much flexibility. And apart from general practice, there were very few options for parents. So child and family health nurses do offer some limited services in some areas. We have the AMSs. One city council still immunizes in Maitland, but even these services lack flexible options like outreach, home visiting, drop-in clinics, and after-hours availability. And we also found, I guess, within the model that reminders and recalls are not used consistently, and opportunistic immunization is just not often the core business. These limitations are often entrenched within the models of care themselves. And we heard a lot of things like, we don't do home visits. We don't have time to send reminders. We have other KPIs. It's parents' responsibility to get to us. We couldn't be more proactive. Other similarities were, while Aboriginal communities and participants reported specific barriers and enablers. So as we mentioned, that lack of cultural safety and services, and just not being enough Aboriginal health workers available. Systemic racism and transport was a significant problem for Aboriginal families. Aboriginal families mentioned the importance of family support, and that if you had family support, it was much easier to get an appointment and make it all happen on the day. And if you didn't have that support, it was just, even harder. One Aboriginal service provider said, in a non-Aboriginal setting, they're feeling that people are looking at them and judging them, whether their appearance or whether their kids are being naughty. It's just that stigma that Aboriginal people don't immunize our kids because they're drunk or they're using drugs. There's all this racial stuff, but a lot of them don't go into that center. that government health service. We also found that the use of air data, we found that readily available air data was not used to its full advantage. So that means it was not analyzed regularly at small populations, not shared with partners or used to plan immunization services to extend reach in areas where access barriers exist. And this may have been due to resource constraints, as it is time consuming to do all of that. Someone said, we've got really good systems to get the data out to people, but it's just a scale problem. And there's not a stakeholder meeting in the area. It's not something we've adopted here just because of resources. And many people in our projects were quite surprised to hear that they were living and working in a pocket of low immunization coverage. Someone said, we've always been told 95% in Tamworth. We've been the top of Australia for I don't know how long. We're not really sure where it's fallen down. We also found that there were many opportunities to build on. So there are those other services that are providing some service, and there could be some just opportunity there for making some adjustments to improve that access and that flexibility. And we'll look at some of those options a bit later. Our studies really found a lot of similarities, really more than differences, but there were some important local differences. For example, in Tamworth, families and Aboriginal service providers felt that information provided needed to be provided in culturally appropriate ways. So that might be in groups with respected community members, using less printed handouts and more artistic methods, including storytelling or artwork. And it was important to link culture with positive health messages that were endorsed by respected community members, and that this would really help parents make decisions. This was thought to be especially important for those young single moms who don't have family support or role models to pass down the positive messages about the benefits of immunization. And in COSSI, we found significant problems in workforce recruitment and retention, particularly GPs, but also Aboriginal health workers and nurses. And this made it really difficult to get an appointment anywhere without a long waiting time. So if you had to reschedule, well, your child is certainly going to fall behind and you are going to get a letter from Centrelink. So someone said there's so much demand for a child and family appointment that you just can't keep up. And a mum said, our doctor has left. I don't have a doctor now. If my kid gets sick, I have to ring around every surgery, basically begging for my child to be seen. And the other issue in COSSI, as Kasia has mentioned, is understanding the history of racist policies and the acceptance of racist views as normal. The implications of racism are not well understood in some services in COSSI, and there is a lot of work to be done to ensure that Aboriginal families feel safe and welcome at all health services. It was in Lismore where we found some hesitant parents, primarily among the non-Aboriginal mums. Like some mums said, I didn't start his immunization until he was 18 months. He was just small. I didn't feel like it was the right thing to do. I didn't want to be in charge of hurting him. Another mum said, I was scared that a severe immune reaction would trigger onset of autism in her as well. So there were several of these kind of worries and concerns. The Aboriginal mums were much more accepting of immunization, but struggled with all the other barriers. So now we're going to have a look at some of these lenses. This is the way that, I guess, how we adopt perspectives in analyzing the qualitative data. So we all use a variety of lenses or perspectives when we're conducting qualitative research. These are apparent in the questions we ask, the way we analyze data, and the way we develop our discussion. So you might think of lenses as part of our insider-outsider perspectives, or the hats we wear, or our individual biases. And Kasia and I highlight three lenses that were most relevant to our TIP approach. The first one is the socioeconomic lens. And this is an awareness that finances and social circumstances play a significant role in how we access healthcare, and that there are a large proportion of children living in poverty in Australia. Some of the socioeconomic factors include really the money that households have to spend on the bare necessities like food, housing, and utilities, and this increasing cost of living. And this money is coming from increasingly insecure employment, underemployment, stagnant wage growth, and a gender gap in pay. There are out-of-pocket costs associated with accessing primary health care, and these costs can mean parents avoid making appointments, especially for something like preventative care when your child is not even sick. Some of the social factors include dealing with poor mental health, domestic violence, and drug and alcohol problems, although these problems certainly pervade all sectors of Australian society. And this lens helps us to understand why immunization may not be a priority for families, even though they're not opposed to it. And working with Aboriginal researchers to help us understand what Aboriginal participants are telling us is crucial. And we were able to adopt this cultural lens when working with our in the Aboriginal projects. And there's this great saying that there's no research on us without us. And you may have heard that before, as Aboriginal people are so overly researched upon. So in Tamworth, we worked largely with Aboriginal researchers from the Public Health Unit. Our study was led by Aboriginal people, and the governance was also provided by Aboriginal researchers. We had a series of two-way learning workshops where we went to Tamworth and we learned about some of the issues that were affecting Aboriginal people. And that picture on the side is from Kylie Taylor, who showed us the cultural iceberg and all the things that are just on the tip, but what's really going on underneath that's also important to understand. So we learned about how to ensure cultural safety in our study, appropriate use of language. Aboriginal researchers conducted the interviews or co-facilitated them and the small group discussions. They played a crucial role in the data analysis and the interpretation. So helping us to understand maybe, or not to misunderstand what people were saying in these transcripts, and making sure that our findings were useful to Aboriginal communities and services. And we adopted what's called a strengths-based approach, and there's a great resource there from the Loitcha Centre, about the deficit discourse. So we're moving away from negative language problems, just focusing on problems and blaming, towards a more positive identifying opportunities and building on strengths. And also the cultural lenses as well include called families and how information services work or don't work for them. Like one person in Maitland said, in some families, the wife is from a called background and would like to be informed as well, but they're not at that language level. So that creates a barrier for them and they feel that they aren't part of it. And we would also like to focus on the gender lens, which is really like the elephant in the room. This lens exposed the entrenched assumptions that child rearing and childhood immunization are women's responsibility, and that women shoulder the responsibility for the physical and emotional loads related to family life. This term emotional load refers to this continuous cycle of thinking, planning, and organizing domestic life and how exhausting it is. And you can check out the ABC podcast for more about this. But again, as women are really mired in these multiple responsibilities, juggling tasks, planning ahead, organizing transport and childcare, getting the pram on the bus or pushing it up the hill in the hot summer weather, immunization can just slip down the list of priorities. And single moms are often judged in our society as being an unproductive burden. So one mom said, I could only imagine if you had more than one child and you're a single mom or you're juggling kids, you're going to try and pick them up from school. It's just too hard. Or someone said, maybe they're judging sometimes because you're not on time Your kid was supposed to be immunized a month ago. You're getting that judgment straight up. So personally, it's hard to think of men living this experience. I mean, of course, there are probably some dads out there who get the pram on the bus and pick up the shopping on the way home, keeping their anxiety in check. But it just seems sort of absurd, almost like a joke. And these three lenses do not operate in isolation, but usually in combination. So you could imagine this would be heightening their effects. And while we can't fix these problems today, it's the awareness of them and the impact they have on keeping children up to date that's important. So this awareness supports our efforts to reorient health services and remove those access barriers. So let's look now at some of the models and frameworks that we've used in TIP. Kasia?
Right. In the next few slides, we're going to be looking at different theoretical frameworks or models we drew on. And we're going to, I guess, critique them or question some of them. So TIP is underpinned by COSSI theoretical model of behavior change, where researchers are encouraged to group findings according to capability, social and physical opportunity, and motivation factors. Tailored strategies can then be designed to target those factors. COSSI has been recently adapted for childhood immunization. Across our studies, with the exception of some parents in Lismore, as Susan mentioned, we found that both parents and health providers alike were supportive of and committed to childhood immunization. So the reasons for under-immunization and the strategies to address them did not fall under the individual capability and motivational factors. They did not fall clearly under the opportunity factors either. So we looked into other frameworks to provide us with a better language to describe what we were seeing in terms of those broader social, cultural, and structural factors influencing immunization, those lenses that Susan just mentioned before. For example, the socio-ecological model of health can be used to help describe more clearly those broader determinants of childhood immunization, including policy, organizational, community, and interpersonal factors. Or, in helping us understand the social context around child immunization in Umina, Central Coast, we drew on a conceptual framework for action on the social determinants of health. That framework differentiates between downstream factors that are in turn influenced by midstream and upstream factors. And using that framework, we found a helpful language to describe what we observed and the likely relationship between factors influencing childhood immunization. For example, in Umina, we observed, as Susan mentioned, that the community experienced many midstream challenges, such as difficulty accessing health services, living with socioeconomic disadvantage, and lack of suitable transport. And that those midstream factors were in turn influenced by a range of upstream factors, such as Australian policies contributing to housing unaffordability and work casualization, GP practice model, or policies which increasingly shift the costs for childhood immunization from public health to private practices and to parents. So in summary, in doing social research in immunization, we should not feel the need to adhere to any one particular theoretical framework or model, or use them prescriptively, or try to feed the reality into a particular model. In light of what we just discussed as this complexity of the determinants or lenses that influence on people's day-to-day life, including immunization behaviors, we actually need to draw on various frameworks to better describe the complexity. It takes time and effort to explore those broader factors, but social science has the responsibility to highlight and address that complexity. And as we mentioned before, we also can draw on plethora of methods in social sciences. So we have the tools across diverse fields of social science to actually describe that complexity. Back to Susan now.
All right, thank you, Kasia. So now we're going to just have a look at some of the implications, like what's the value of all this that we have found and we've been talking about. For the service delivery, we felt it's really important to address gaps in local health service delivery in both the public and private sectors. And that's really about more support for families to help them access services. Maybe revising service models to ensure that immunization is once again core business. Providing greater flexibility, and here are these things again, the drop-in, the after hours, the outreach, the home visiting, the reminders, and the opportunistic immunization. I mean, these are things that used to be commonplace and are now bit by bit sort of falling away. And also strengthening the workforce recruitment and retention, especially in those rural areas. One person said early on in the research, the only way you'll get that cohort you're focusing on is to have opportunistic immunization. There's no problem with home visits. Having vaccines in the car and saying the child is overdue and asking them if they'd like me to do it now. No one ever says no. And another person said having individuals, I guess these are like the immunization champions, having individuals who are very committed makes a huge difference because they're going to go the extra mile. And it's often that extra mile that's needed, chasing the families, being flexible, not too rigid, and making sure the system enables that. And it's important to recognize that the culturally appropriate health services, like the AMSs, are really important pillars in childhood immunization for Aboriginal people. And the role of the Aboriginal immunization health worker, which was created in New South Wales, is really a key position. It is effective and well accepted in the community, helping to identify overdue kids and helping families connect to culturally safe services. However, it's not realistic to think that one person is able to overcome these structural barriers and systemic racism and to deal with all of those things. And they are working across a region, not just in pockets. This role could be tailored to meet local needs and to help address those unique barriers. The Aboriginal Immunization Task Force can help play a central role. And it's always important to remember the importance of community consultation to make sure that community has a voice in identifying the needs that are important to them that need to be addressed in the AMSs. So in terms of public health, the implications are, well, we've done 5 studies now, and I think we have contributed to the evidence base that can inform change locally, but also more broadly in New South Wales. We know that routinely available data can be better used for planning, monitoring, and evaluating service delivery. As someone said, AIR has gradually improved to what it is now. I mean, we know there were and there are still some problems with that register, but the whole system has been tweaked nationally over the decades to get it where it is now, which is a fantastic resource. And public health can play a role in developing these stronger, more formal partnerships at the local level. Because a lot of people are not meeting each other, they're not talking, they don't know who they are. And those should include population health, community health, child and family, the PHN, all of those that have a stake in immunization. And we found in some of our projects, some people were meeting, but others were left out of this group. It's important to have not only service providers who will be doing immunization and their managers, but also some executive involvement, more people who have the authority, and the power to make change in health services. So, next steps? Well, we do have to progress to co-design tailored strategies in Umina, Kempsey, Lismore, and Tamworth. And this really has been challenging because we don't have any additional resources to do it. And there's that question of, well, who is going to do it? And when are they going to do it? How are they going to do it? or what are they going to stop doing, in order to allow them time to work on this? In terms of scaling up TIP in New South Wales or beyond, we have developed these two concepts, like a basket of evidence-based strategies and a community of practice. So the basket of strategies, or after following the TIP phases, the formative research that we've talked about, people could select evidence-based strategies from this basket, and that they could be further tailored to meet the local needs through ongoing consultation with partners. So, you may not have to develop a strategy yourself. You could look in the basket and say, well, there's outreach, there's personalized friendly reminders, there's drop-in models or after hours. So, you could select from that. And a community of practice is really a group of people who have experience using the TIP approach, who come together to support each other and share experiences. And this group can then offer help to those who are thinking of using TIP in their local health district or their public health unit. And this group is just starting to form now with membership from the 5 projects. So after developing a tailored strategy in Maitland that included friendly reminders, outreach appointments, and home visiting by child and family health nurses, the coverage rates have been slowly but steadily improving. So we've seen an 18% increase over 4 years in our target group of 1-year-olds. And even more interesting is this quarterly data from our data analyst Fakrul Islam in Newcastle, who's really streamlined the data analysis. And in 2020, the number of overdue 1-year-olds in Maitland has continued to decline. So even in the second quarter, when COVID restrictions had us worried that children would fall behind in their immunization, and it hasn't been the case. So these results are promising and tell us that TIP is working. TIP is not a quick fix, and change in service delivery just can't happen overnight. The changes in Maitland could not have occurred without the commitment and hard work of a team of people who've come together every month to make sure that the new strategy was fully implemented and is working well. But that's really what TIP is all about, really bringing people together to understand the context, work out what needs to be done, then do it and check that it's working. I mean, sort of sounds simple, but it does require a methodical approach, perseverance, and belief in the end goal. Here's that slide of acknowledgements of the many people and organizations who have been involved in the TIP projects. And without them, of course, we wouldn't have projects. So, Kasia, I'm going to ask you now, as you've been working on TIP for a number of years in a number of situations. What are some of the things that have sort of made the biggest impact on you?
Well, I don't know if they made the biggest impact on me, but what is really striking to me that in each project, in each community, we heard about those broader socioeconomic, cultural, and access barriers, and how they really impact on people's day-to-day lives. We simply cannot ignore that broader social context in public health or immunization science in particular. And another thing that is probably something that I learned, I became really aware of, is that we have worked with some disadvantaged communities, and in a mindset of troubleshooting, it would be easy to focus on the deficit, on the things that don't work. But it's so important that in public health research and immunization research specifically, we don't forget to ask people what does work, or what makes you proud, or what would you like to build on. In our studies, we found things such as existing immunization networks, or immunization champions, or positive community perceptions that really help promote vaccination. So I guess learning for me is that effective programs need to build on those local strengths. What about you, Susan? What really has been yeah, impactful for you across those
Okay.
two studies?
Well, I mean, I really appreciate that we've had time to complete 5 studies over 4 years. And this has really allowed us to delve more deeply into these structural barriers, using social science to build our knowledge and really get a better understanding of what lies beneath those sort of commonly heard themes of socioeconomic barriers or conflicting priorities. Like, what does it all really mean? Where is it all? Where is it all coming from? And just lastly, I mean, now we know about the pockets of low coverage. We have a lot of evidence to inform change. So if we don't develop new ways of providing immunization to families, then, I mean, are we really saying that we're happy with the status quo? We are happy for those children and those communities to remain at risk? I mean, there are a large number of policies that address these issues of equity and access. So I say let's use them to create that change.
I agree. We'd like to just invite you now to, we're going to stop sharing probably our slide. Yeah. And we'd love to hear from you. What are some of the things that maybe this presentation, brought your key take-home messages from what you heard, or if you have any questions or comments?
Thanks, Kasia and Susan. That was brilliant.